Now for the very awaited talk by keynote address by Dr. SHARON DSOUZA. So this is the Shiv Prasad Hadya Award. She's going to talk to us on the effect of cap depth in SMILE on clinical, biomechanical, and molecular outcomes.
Good morning, everyone. I think it is my honor to be a part of this session. Those were very, very nice talks, very interesting. I think I learned so much. So I thank all of you and the AIOC for this award last year and to make me a part and allow me to present it again here. So I think after hearing those wonderful talks about SMILE, this is a little, just a concept, because we know that the SMILE cap can be made at various depths. And there are some papers which suggest that you can do it at 100, 150, 160. But is there any reason to choose between those? Is it just the refraction that we're looking at, curvature, or is there something more? And does it really make a difference to our outcomes in general? So we know that one of the things that the cap or in any incision in the cornea can affect is the nerves, because our subbasal plexus of nerves run just below our Bowman's layer, which is around 50 microns and extends to about 30 microns beyond that. So we know these nerves are very, very important for the sensory and reflex functions, our tear secretions, the sensations on the cornea, and also wound healing. So they do maintain the ocular surface health. When we do a SMILE or any refractive surgery, even in LASIK, there is certain transection of the nerves. The good thing is that in SMILE, because the incision is much smaller and the cap then is below, the amount of nerve transection is less for sure. But unfortunately, it is not zero. So there is definitely some effect that happens because of the SMILE surgery. Again, it has been shown that once the nerves are transected, there is a re-innervation which happens, and this is definitely higher than other refractive surgeries, but none of them actually recover to a full degree, and it varies a lot. So we know that the SMILE cap depth could have some effect on the surface inflammation, but does preserving it, the corollary, is it true that if we go that extra mile to try and preserve the nerves, would it then help us in any way? So that's what this entire study was. So the knowledge gap is that we know it can affect all of these, and we wanted to put it all together to try and see how it actually looks at our outcomes in a clinical scenario. So what we did was we took patients who were planned for SMILE, a regular SMILE surgery. Of course, the usual exclusion criteria for these refractive surgeries were followed. It was prospective interventional, and it was a contralateral eye study. So one eye had a cap depth of 100 microns, and the other was 150 microns, and 40 patients were chosen. The refractive workup, the preoperative workup remained exactly the same as we do for SMILE surgery, but we made sure that we also had an assessment of the optical quality, which was very important because we need to see it post-op, detailed dry eye evaluation, and molecular factors to see if the inflammation on the surface had changed. All of these surgeries had all the parameters exactly the same in both eyes, same surgeon, same parameters, and same diameter, and except for the depth differences. So the various outcome measures which were looked at were, of course, the visual acuity and the quality, because we know that scatter can be there if there's a lot of scarring. We looked at the nerves pre and post-operatively, how's the epithelial mapping changed, and looked to see if there's any nerve degeneration in these patients, and also if their dry eye parameters changed. And this was recorded pre-operatively 1 month, 3 months, and 6 months. Very interestingly, we found that even though initially there seems to be a lesser reduction in the Schirmer score at 1 month in the 150 micron group, by around 6 months or so, it comes back to near normal, and both groups seem to do almost the same. Again, similarly, there was no significant difference when we looked at their vision, both the quantity and the quality. The optical outcomes were also very comparable, all through in both the cap depths. So till now, we are feeling quite reassured that we're not doing any damage with either. Again, even in the corneal biomechanics, both the 100 micron and 150 micron cap depths were comparable, and there was no problem. The difference came here. When we looked at the nerve regeneration, the 100 microns cap depth at 1 month, if you see the second confocal image, there seems to be, very few nerves that are visible, and this was seen across almost the entire group. But reassuringly, by around 3 to 6 months, this does regenerate. The 150 micron cap depth did slightly better, so there was less transections of the nerves, which is logically, what we would expect. It's a deeper cap, so it doesn't affect the subbasal plexus as much. But of course, by around 6 months, they're all coming back to near normal. The inflammatory cytokines, again, was the converse. In the 150 cap depth, it seems that there's a slightly increase in the amount of inflammation that is generated, and also the extracellular matrix modulators are altered a little more. What this would imply to us clinically or logically, we would expect that then in those patients, we may have some amount of, more scarring if we don't handle it better. So this is a summary of what we found, where there was not really that much of anti-inflammatory or pro-inflammatory changes, but the extracellular matrix factors did show a change. So would it affect our wound healing response? As I said, there has been some excellent work before trying to look at different cap depths, and we wanted to put this all into one umbrella to try and understand what we have. So at the deeper cap depths, we found there's earlier nerve regeneration, faster recovery of the subbasal plexus of nerves, which was seen all through. The baseline parameters, does it matter? It seems that, over time, it all comes back to normal. By around 6 months to 1 year, we are looking at both groups doing fairly well. So what we're looking at is that the subbasal nerve density may not reach the pre-post-operative factors, but it is recovering fairly well. And most of them did recover their baseline levels at 6 months post-op. The deeper cap is very good, as effective in all other parameters, so there's really not that much to change it. How this applies to our results in the clinic is that when we are looking at doing a patient who needs a deeper cap for whatever our clinical reasons, since we know that they may have a little more post-operative inflammation, pre-operatively try to handle these a little better. If they have things like contact lens intolerance, dry eye, or any of these surrogate markers of an ocular surface disease, be a little more aggressive in treating it well so that we don't have any post-operative problem, because they may have some pre-existing disease. Thank you very much for listening.
Thank you, Dr. Sharon. So that was wonderful. So we have exactly 5 minutes for any discussion, any questions from the audience or any discussion among here. Now, we don't have Dr. Sheetal, who was supposed to talk to us about hyperopia. Maybe I should ask a few questions to Dr. Rupal about the hyperopia treatment in SMILE and how soon we can expect to have it.
So we had the chance of doing some hyperopic patients, about 100 eyes more than 10 years ago, and the results at that time was also quite promising for hyperopia up to about 4 diopters. Beyond that, anyway on the cornea to do a hyperopic treatment usually doesn't lead to very stable results and leads to a lot of aberrations. So results were comparable to LASIK. And I was actually expecting it to be released quite soon after that. But there are newer parameter settings. And of course, now with 800 Pro, they need to do some more studies with the newer lasers to release hyperopia along with because all the studies were done with the older lasers. But they can actually transfer the data and work on the Pro 800, VisuMax 800 much faster. So I think it should be there in the next year or so. Having said that, hyperopic patients are not a big chunk of what we do in terms of refractive surgery on the cornea. And therefore, right now it's still worth to do the SMILE procedures and to have it included in your armamentarium, because it's fast becoming the procedure of choice. So you should not be really be left out of this wave of SMILE.
Actually, there's some indication that they're going to release it in about 6 months or so. But believe me, they've been telling 6 months hyperopia is in the pathway for the last 8 years. So that's a different story. But this time they're possibly going to come out, and probably in a year to 2 years, we should have mixed astigmatism also. somewhere about 1 year to 2 years from now, we should be having the Press Beyond available on this platform. The third one is they're going to come out with some kind of customization also. So now I think they're going to come out purely at a faster pace, not because suddenly they've woken up to science and other facts. Now that you're under commercial pressure, you have 3 other companies in the pathway and they're already marketing. So I think that would light a fire under the tail of Zeiss, and they're going to start doing things a little faster.
It was high time it happened. I also, there's also going to be Smile as a retreatment option for Smile, which has also been getting tried at several places. I have done a couple of cases. It did work well, but it does definitely require more work to be done on that. So that's where it stands today. I just had a small question for you, Karthikeya. Do you do any nomogram adjustment?
Not a nomogram per se, but what we do is for sphere, we overcorrect by 0.25, ma'am. So yeah, so we overcorrect all of our patients by 0.25. When you don't do this overcorrection, I feel the post-op residual is between minus 0.25 and minus 0.5. Yes. So, but when I overcorrect by 0.25, it lands between, post-op refraction lands between minus 0.25 and plus 0.25. So I feel that's a better result.
Ma'am, I have a question to ask you, sorry. So, as you rightly said, retreatment options for Smile. I personally believe lenticular extraction is the future of refractive surgery. So, creating a circle again which will weaken the cornea, I might not favor as a procedure of choice for retreatment. And with Dr. Sharon's presentation talking about the deeper cap there, when we talk about the retreatment Smile options, do we prefer within the Smile cap or something below the Smile cap?
So what I have done is considered the base, the stromal bed, as the posterior part of the lenticule, and done the anterior one. But because it was a very small myopia that we treated. What other people have also done is gone 20 to 30 microns deeper if they had a cap which was very thin from the base, and so that they don't go and approach the same plane again, and created another lenticule there. So that's why I was saying that it does require more treatment, more
studies
work,
too,
because it's not again as easy to calculate as what you would feel that one diopter would not translate into one diopter, because there are going to be 2 lens within the same corneas, 2 shape change. So how the rays would bend, that needs to be calculated. So it does require a very refined software to be able to do a smile on smile and not just feed in the data and do the treatment as we do.
So that's a different software which has to be incorporated.
That's why I think they are also have to work a little more on this.